about to do. So welcome to the second spotlight session as part of QI week. And this focus today is on the team, our team at Somerset NHS Foundation Trust. And it's just a chance for people to, these sessions are a chance for people to showcase the improvement work that they've been doing and to share with others sort of around the NHS, around what they're doing. So my role, my name is Jess Pawley. I'm a knowledge and evidence specialist with the team, and I'll be speaking a bit later on about my role and what I do. But for the moment, I'm going to hand over to Greg Cobb, who is the Associate Director of Improvement, Research and Development. Thank you,
Thanks,
Greg.
Jess. So just start off with a little bit of an overview of Somerset and Somerset Foundation Trust. So Somerset Foundation Trust was made up of the merger of Musgrove Park Hospital, Somerset Partnership, which was the Community and Mental Health Trust, and Yeovil District Hospital. We're the only provider of secondary care in Somerset, so it's one provider for the whole of secondary care. We also provide about a quarter of primary care services in Somerset as well. So all of that together, I think, makes us, we're the largest non-teaching trust in the country. And we're also the only provider of size that's got the whole gamut from primary care to mental health to acute services, all in one organisation. The population of Somerset is about 550,000. It's a very rural county if you don't know it. The population in some areas is quite dispersed, and we also can boast some of the oldest populations of any area in the country. So the things that are occupying the trust at the moment in terms of its strategic priorities will be the same as pretty much everywhere else, understanding the impact of the 10-year plan and what the new arrangements are going to be. Making sure that we can keep our financial sustainability and our performance in a good place, same as everywhere else. We're doing okay on both financial and performance at the moment, but lots of concern and lots of work going on to try to make sure that we can hold that position, particularly with winter pressures coming along. On a more kind of broad and strategic sense, so we've obviously got winter pressures and we've obviously got the usual performance and financial issues, but also the trust has got a real desire to exploit its position of being a fully integrated trust to really try to explore new models of care and really start to move into more of a population health prevention way of working than we had before. At the core to how we operate is our improvement approach and our improvement methodology. And that really underpins how we're intending on progressing those strategic priorities. So if I say a little bit about the team and about how we formed, so the origins of the team in its current form go back to about 2016, when we were separate organisations then, we were just Musgrove, and our board made a substantial investment in the improvement team, really with the objective of getting improvement methodology to be core to the way the organisation operates. So at that time, we went from a team that was around 4 to 45. So it was a very bold investment, and probably at the time, one of the biggest in the country. Not anymore. Lots of other places have done that since. The improvement team model that we've got is slightly unusual. I'm not sure if there are many places where the improvement team incorporates a bunch of different disciplines. So we've got quality improvement in there, we've got program management, project management, we've got a transformation team, we've got knowledge and evidence specialism, and we've also got a data science team that all come under the umbrella of improvement. The primary objective of our team is really to raise the capability of the organisation to design and deliver effective change programs themselves. And core to the way we operate is our central improvement team doesn't own and doesn't run the projects in the organisation. All of the programs and all of the projects are owned by our operational teams, and the central team supports them. the idea of that was to be really clear and really set the tone in the organization that improvement was a business as usual activity. It's core to our operational delivery, and it isn't something that's done to our operational teams by a separate group. So that's a bit of an overview of the team, and I'm happy to take any questions at the end. There's obviously lots more detail that we can go into, but I'll hand you over to Rachel now, who's going to talk about our culture of improvement survey. You're on mute, Rachel.
You think I'd have got this right by now, wouldn't you? Hi, everyone. I'm Rachel Dons. I'm a consultant anaesthetist at our Yeovil acute site, but I also have the privilege of being our Associate Medical Director for improvement across Somerset Foundation Trust. So our culture of QI survey was kind of born out of three things. What does our culture of continuous improvement look like across our organisation? The first and most important thing, really, but also to assess the impact of our training offers as an organisation. What is the efficacy of those training offers? What are people doing with those training offers when they have finished their training with us and they go out into the wider organisation? But also the other thing that I think the thing that occupies quite a lot of us really is, what does the culture of our organisation look like? Could this be a proxy measure of the culture of our organisation? So those are the three things that we sort of started with. Next slide, please, Jess. So back in autumn 2024, we designed a bespoke survey with two members of our team, a communication specialist and one of our data scientists, came up with this and made this real. So we designed it, and our questions were informed by the 5 key components from the NHS Impact and the evaluation of the Virginia Mason Institute and NHS partnership, which was published back in spring 2023, which looked at the potential link between the quality improvement landscape, if you like, of an organisation and performance. So the survey was designed and we shared it with 1,800 colleagues who had previously attended improvement training. We got about 203 responses back. But the format, we looked at a number of different questions to try and get as much information out of this as possible. We looked at the demographics, where people are in the organisation. We looked at questions like our questions, which measured agreement levels to statements about your experience of QI. What are you doing at the moment? How many projects have you been involved in recently? Open-ended qualitative feedback, but probably for me the most important aspect of it was the network analysis, because that gives us an idea of what the collaboration and communication about QI looks like across our organisation. We all know from the Virginia Mason and NHS partnership that QI is a socio-technical thing, the technical side of it being giving people the tools and techniques to do QI, but there's also a social side. What are people doing about QI? Who's talking to who? What do you do with that information? Next slide, please, Jess. So we came up with a number of things. We came up with 6 primary things that we sort of split out into barriers to improvement. It'll come as no surprise to anyone on this call that time constraints are probably the biggest barrier to improvement. But we also identified that management support was potentially a little bit inconsistent across our organisation. Senior support is there verbally, but not necessarily practically. And sometimes I don't see senior leaders role modelling a QI approach. So these are things from people who've undergone QI training within our organisation. Another thing that was identified was improvement support. Hands-on learning, accessible resources. So supporting these people once we've trained them to go out and do QI across their organisation. And also staff engagement. We're in a difficult landscape at the moment, as Greg has already alluded to. We've undergone 2 mergers in the last few years. The last one is only 2 years old. There is change fatigue and low morale impacting willingness across the organisation to engage in QI. Next slide, please, Jess. So what would help? We asked people what would help. No surprises there. Prioritise time for improvement. People want dedicated time for improvement. And we've tried to address this with some of our QI offerings. Gold QI is 6 days over 6 months with some dedicated time to do the improvement. So time set aside specifically for improvement. Our teams felt that Empowering managers, improvement champions would help. Again, ensuring accessible ongoing improvement support. And create a culture of improvement, addressing those factors contributing to low morale, change fatigue, recognise contributions and support colleagues to embrace change. So from these, I think it's important to note some of the comments that we've had there: improved headroom to allow staff to formulate and implement QI work, visibility of improvement work projects. So those are the four main areas. So next slide, please, Jess. There were two more that came out of the Likert questions, which the first one probably supports the comments I've already made. I feel well informed about improvement initiatives happening across SFT. That's something that we do need to look at. And the last one, patients and carers have opportunities to improve and participate in improvement projects at SFT. That was a very big thing that came out, which I think is probably a theme running through improvement work right across the NHS currently. So of those 5 particular areas, there are some that we can do as a team, and we are taking steps to look at how we can improve those in terms of podcasts. We are looking to share the quality improvement projects that are going on in the organisation at the moment. We're looking to streamline and align our quality improvement. We don't have a vast resource, as Greg has already said, so that we can streamline and align our quality improvement projects across the organisation alongside the strategic aims of the trust going forwards. Next slide, please, Jess. So I've already alluded to the fact that I think one of the most important things from this piece of work is probably the social network analysis. This highlights the relationship between relational connectedness, improvement culture and performance. And this was very much a very visual view of how QI looks within various organisations from the Virginia Mason Partnership and the NHS. So we have Trust Day, which is outstanding. There are a high number of connections. Everyone's talking about QI. People are taking the tools and techniques that they're given and they're talking about it. They're utilising it. They're talking about improvement. And Trust D, which is special measures, there's sort of like a chain-like picture more to it and less connections. And from the Virginia Mason Partnership, we know that Trust D was probably one where people focused on the technical side of QI and didn't really look at the social network aspect of QI. So that's one of the things that we're sort of looking at for us as an organisation. Next slide, please, Jess. So it's the absolute nuts and bolts of this, really. This is the social network analysis for Somerset SFT in terms of its continuous improvement landscape, as it were. So you'll see from this, it's quite a difficult thing to look at and analyse and takes time to analyse. It is 3D. You can't see that in this particular presentation. But I think the things that strike us most clearly are that we have a really good interconnected central core here at SFT, but we do have a number of what I call jumping jacks around the outside, which we know because as a team who've done the survey, we can zero in to find who these people are, what their level of training, what particular area of the organisation they are actually in at the moment. So the jumping jacks really show various people who've received training and who are doing QI within their own particular areas. There are also some isolated dots around the outside, which we think predominantly show our bronze QI training offer, which was only ever designed to show people what the terms and what basic QI looks like and give them some of the tools and techniques to be able to understand what QI is. So you'll all notice there are different colour lines in there. When we sent out the survey, one of the things we wanted to know is how connected you are within the organisation. We asked people to define their relationships with people within this network as a QI advisor, which is the green lines, QI collaborator, that's the red lines, and black, which is a QI leader. So we'd have some idea of what those relationships look like across the trust. So we are just about to repeat this year. We are going to include our project management offering into it this year, and we will be able to analyse what our project management offer looks like across the organisation and our quality improvement offer across the organisation. The aim being that we are a new, young organisation going forwards. And actually, as Greg keeps telling me, culture change takes 5 to 8 years in any organisation. So the ambition would be, as we increase our numbers of people trained, and as QI gains a much higher profile, shall we say, across the organisation, that the connections across the trust will increase. And hopefully we'll have everybody talking to everybody about improvement across the organisation. The other thing to say about this particular piece of work is that it is a fabulous piece of work and has delivered significantly more than I ever imagined it would do. We are able to drill down into each area, each service, each directorate to look what quality improvement actually looks like within each of those areas, and will aid our teams going forwards with a little bit about potentially that proxy measure of culture within their particular areas. So I think that's my bit. And I think, as Greg says, I think there'll be an opportunity for questions at the end. Thank you.
Thank you, Rachel. I'll hand over to Karen now, please. Thank you. I'll just move the slide.
Thanks, Jess. So I've got a few minutes just to talk about the clinical transformation team. So my name's Karen Holden. I'm the Associate Director for Clinical Transformation, part of the improvement team. So we're a small group of senior colleagues whose role is to act as custodians for the clinical care and support strategy. So that's what I've got very briefly described on the slide. So and you'll see from our backdrops as well. So in a sense, we help develop the clinical strategy for the trust, but we also want to keep it live. So we want to make sure it stays in line with national and local priorities, but also to make sure that any strategies being developed across the trust, any plans and programmes for change are in line with it, so that we're all pulling in the same direction. So that's our sort of primary role. We are made up of myself, and then I have 2 clinical transformation advisors working with me, so Claire Evans and Zoe Hamilton. And we also have a new role for us, which is Dr. Florence Locke, and she's an acting consultant for public health, brought in to support the framework that, and the drive that we need around aim 1, which is to look at the population health approach for the trust. So that's really new for us, but really exciting. It was an area that we recognised was a gap. Whilst there was work happening, we just didn't have a sort of coordinated approach to bring that all together. So that's fairly hot off the press for us. So I was asked to describe what we do on a day-to-day basis. Well, we work with teams from sort of various ends of the scale, both where there's a burning platform, that means that we need to bring in sort of rapid and phased changes, working with teams that are maybe in a state of distress over the changes that might need to be made, but also some very specific concerns that we're needing to work with. But we also work at the other end of the scale, where there's some really good ideas, there's sort of sparks of things that we know that if we could grow would really help us in terms of the delivery of our clinical strategy. So it's about us providing both extra capacity and expertise, bringing along sort of influence, bringing in tools, knowledge, experience, whatever we can, acting both as critical friends, but also a sort of form of peer support to the leaders that are working on in those areas. We have a role to kind of make really good connections across our systems, so making sure that we're aligned with partners and where we can to use our influence in developing strategies and plans. So we're sort of supporting our organisation in terms of sort of stretching what it can do, but also being realistic about what's achievable. We do this often in environments that are quite emotionally charged, so we do need to have a sort of level of skills about really understanding people, understanding teams and understanding change. So that sort of whole piece around culture is something that's really key to the work that we do for the trust. So, and also as others were describing before, our job is as part of the improvement team is to build capability. So it's not that we just go in and do, but actually our job is to work alongside the leads and the teams in order to support them to grow and develop and build their confidence. So we do a lot of coaching, mentoring as part of our role, as well as providing some direct support. We hold a portfolio of programs that we support across the organisation. And we also work with some leaders within the trust to help really about the sort of longer term thinking. So our job is to make sure we've had the capacity to do a lot of the reading, a lot of the understanding, notice things in the research and emerging evidence in order to be able to help apply that, so that we're not just continuously in a place of firefighting, but actually really thinking about where we want to be in the future and what we need to do in order to get there. So our work typically comes from word of mouth. So that's where we've been working with teams and they ask for a request. They put in a request for repeat support. We also work very closely with the rest of the improvement team. So we get along to, for example, the gold training. So we can hear what teams are working on and see if there's anything that would be really useful for us to add our extra skills and experience into. And the same with our project management team. So sometimes where the project managers, program managers are working with teams where they may be just sort of struggling with the overall direction of travel and what they want to do, then we can get involved to try and help put the basis of that into place. So we do occasionally get referrals that come to us directly through our triaging for us, but it is more typically through word of mouth and through the rest of our colleagues. And that probably works for us, being as we are quite a limited resource for a trust the size that we are. So I hope that gives you a little bit of insight into our roles at the Trust, but I'm really, as with the others, happy to answer any questions at the end. Thank you very much. Over to you, Jess.
Thank you, Karen. I will now hand over to Claire and Sarah. I'll just move to your slide. Thank you.
Thank you, Jess. Hi, I'm Claire. I'm an improvement advisor and I've worked with the improvement team at SFT for the last 13 years. So I had an overlap of years working with both improvement and clinically as a nurse in critical care and critical outreach for many years. And I think as an IA team, we recognise actually that each of us comes from a different background, and that really adds value to the role that we have. So as IAs, we raise capability for individuals and teams to own their own improvement projects with the training, the using the evidence-based tools and the techniques within our 7 steps methodology. So we deliver the 7 steps at 3 levels. So that's bronze, silver and gold, as well as an introduction to improvement. And they're all variable in length. We've made it so that really the levels are accessible to everybody, either through face-to-face or virtual delivery. So gold is always face-to-face, but silver we can be flexible with the teams, whatever suits them best, whether they want to be in a room together or we can deliver it virtually. We start with the fundamentals of forming a team. And you can see the 7 steps on the slide in front of you. So who needs to be part of the team day to day? Who needs to be involved to influence it or guide the project, and who just needs to be informed? And then we use a variety of problem understanding tools to ensure that the teams are working on and solving the right problem. We then empower the teams to write their own aims, to set their own measures, and generate change ideas and spread success. We're very proud of our training and the way it's developed. We all believe in the methodology and have adapted to the needs of our colleagues, who we know are all incredibly busy. So overall, I'd say it's comprehensive but simple. But the story doesn't stop there, because we recognise that just training and delivering that training is not always enough. So on the back of that, we've also developed the way we deliver it, thinking and building on our own skills as coaches and enablers. And we know how and when to guide, signposting to other disciplines within our own team, like project management, mapping, knowledge and evidence, and data science. And recognizing the important role we play in making connections within our own team, but also across the whole organization. And these are some of the skills that were just highlighted on the slide there. I think our greatest pride and reward is being able to step into any team and enable them to start a quality improvement project, being able to recognize what they need and giving them the tools to grow their own skills and achieve their own success. So we started to think about how do we sort of evidence this going forward? How do we measure and evidence that success? And I'm just going to hand over to Sarah to explain a little bit more about that.
Thanks, Claire. So hi everybody, I'm Sarah. I've been working as an improvement advisor at SFT for 6 years, and I've been in other roles in the NHS for 20 years. So to build on what's already been said, the following are some things that we're working on and have been working on since our last spotlight in 2022. And these are to improve the outputs of our projects and our training efforts. So both the project managers and the improvement advisors are more focused on reviewing the impact of the respective training that we deliver by following up staff as to how it's impacted on their work and practice. This links to the culture of QI work that Rachel was talking about, and that does that in a much more formal way. So we're following up training with coaching to help those who have been trained to go on to apply the theory to their ongoing projects. So an example of this for me was that I worked with a team who were looking at limb contractures. They're a team of therapists, multidisciplinary team across the system. And after they'd completed their silver quality improvement training, they still needed some support to complete the project because they'd only just started it. And so it was lovely for me to see that through me continuing to coach them, the project lead really grew and developed her confidence in leading the project, and they were able to actually test a new tool and then come up with a improved standard way of doing things at the end. And similarly, I've supported some of the chaplains from the chaplaincy team with their gold quality improvement projects, and I continue to work with them as they've gone through a number of changes in the team. They're still working hard on how to work better as a team and deliver more for less. So I'm helping them to continue to use the PDSA method with their change efforts. So the people who complete the silver training are now expected to produce a simple poster or a news article at the end of their training. So we'll now hopefully begin to start seeing some more tangible outputs at the end of that. Our bronze training now has mini project suggestions added to it. So this would be along the lines of, you've done some training, have you considered improving something small? Here's some guidance or help if you'd like to do a small project following your training. Here's some examples of small projects. That's in very early stages of implementation, but again, we're hoping to see more tangible outputs. And even our Introduction to Improvement course, that's just a half-an-hour session for people to just give them an overview of what QI is in Somerset NHS Foundation Trust. With that one, we have produced some targeted versions now. So most notably, there's one for the junior doctors. We realised that for them, they needed much more practical information about how to start a project. and things like differentiating between measurement for quality, measurement for clinical audit and measurement for quality improvement. So we've tried to hone in on those things that were obvious gaps for them. And linked to that, we have a certification process now for people who are increasingly being asked to do quality improvement projects as part of their professional training. So now when they approach us wanting to receive a certificate because they've done a project, we actually support them a lot better by saying to them, you know, here's some criteria of how we can evidence that you've done a quality improvement project. We give them targeted feedback, and then they have the opportunity to enhance what they've done if they want to receive a certificate to say that they participated or actually that they led a quality improvement project that sort of meets a lot of those criteria. So we're tightening up our standards more now, and by doing that we're also receiving the outputs of the project, such as the posters and presentations back, so we actually have more to show for all the work. Another thing we've done is we've moved from having a spreadsheet where we were logging our improvement projects and inquiries to an online system. This has made it much easier for searching for different inquiries and seeing if we have duplicates on there and linking inquiries together and updating the records and uploading supporting information so that we can easily find that for all the inquiries that we have. It also makes it easier to pull reports on the activities that are going on. And as improvement advisors, we follow a triage standard. So this means we can standardise how we respond to inquiries with the emphasis on providing help quickly up front and signposting people and providing guidance on all the things that we know are the recurrent things that they need to know, because we've had a lot of experience of dealing with these inquiries now. We use the database, the online database, to sort of screen for new gold projects. When people apply to do the gold training, we look for similar work. We try to pass on the learning if we can. The wider improvement team have started to upload project outputs into the Insight library repository as well, which Jess may come on to later on when she talks to you. But essentially we're moving to a more system thinking way of looking at things and trying to join up the dots between all of this work that's going on. So there is a few highlights of some of the things that we're pleased to have worked on and continue to develop. And now I'm going to hand back to Claire to talk to you about service user involvement in our improvement projects.
Thank you, Sarah. So as Sarah said, because we talked about colleagues and how we work with them, but we also wanted to share our development of involving those with lived experience in our projects, which ties in nicely with what Rachel was saying earlier to us. So we followed our own methodology, and by listening to our teams, we found the main obstacle was really process and red tape. So we've simplified the process considerably. We offer generic risk assessments, guidance on holding personal details in a simple, safe way, reimbursement for expenses, some of those practical applications. And we've also changed our approach, which I think has been fairly fundamental. And when we're delivering the first step and talk about forming the team, we no longer say, have you considered service users? We say instead, how are you including service users? So what we're really seeking is authentic, meaningful involvement. So those with lived experience are chosen by the team, not from a generic pool. And the teams ask themselves a simple question: who are the majority that represent the views for this project, and who are the missing voices that need to be included? And this is not just for QI projects now it's the expectation with our project management projects. So within within our QI training, we involve simple exercises that require teams to think about those with lived experience, like the De Bono six thinking hats. Importantly, we've defined what involvement is with both minimum and gold standards. So our minimum requirement for QI projects is involvement at the 2nd and 5th steps, which are problem understanding and change ideas. And our gold standard is co-production, which would be including all 7 steps. And it's always lovely to see a team, and I know we had one on gold recently where you've got an idea that came from a patient and they went all the way through the project and then they helped present at the end. So now we've refined that and we know what those standards are, we can log those on the system that as Sarah was telling us about on UTrack. And so we can log those for our gold and silver and PM projects. And finally, we've achieved a multidisciplinary input, both within our teams, so with the PMs, but also with our improvement facilitators, developing emotional mapping. And outside the team, we're working with patient experience team who can offer more expert advice when needed, and an engagement group that stretches across all organisations in Somerset who are involved with service users like Maternity Partners, Health Watch, even the council. And so it's starting to give us a much sort of richer pool in which to get those service users involved. Thank you, Jess.
Lovely, thank you. That just leaves me. I just moved to my slide now. So my slide's a bit different to everybody else's because I have to be different. So I'm a knowledge and evidence specialist with the team, and I provide evidence search support and knowledge management to improvement projects and project management. And I also work with the other disciplines which have been mentioned throughout the call as well. So the main focus of the slide that you can see is a big poster that I was very pleased to be able to present with another colleague around the impact of the work that we do as knowledge and evidence professionals. This was presented at the recent IHI BMJ Patient Safety Conference back in May. Unfortunately, wasn't able to go. It was done online, but I was still very pleased to be there. And it showed the we gave some examples of where we have had good outcomes, positively impacted on patient care and outcomes by providing evidence summaries to improvement projects. And through doing evidence summaries, we can provide the gift of time. This is an NHS England Knowledge and Library Service initiative, which is where evidence professionals, by undertaking evidence searches for you as clinicians or as colleagues, we can save you the time by putting these summaries together and by sort of guiding you to the most appropriate and relevant evidence related to your needs. So we search a range of resources, sort of clinical databases and other sort of more grey literature by using search techniques, which we do train people on as well. So I have a training program that I deliver as part of my role as well. And we like to enable and upskill colleagues to be able to access information for themselves, very much not gatekeeping what we do. It's making it accessible to all. And as part of that, I link back to the wider knowledge and library service. So within the improvement team, it's just me doing this work, but I link back to the wider knowledge and library service within our organisation. I have colleagues working particularly sort of within the research team, the primary care, ICB and the mental health team sort of embedded, much like I am, providing the same service. And throughout this, we have, as I say, knowledge management function, which is sort of asking people, how do you know what you don't know? And taking it back to the improvement 7 steps, at which stage of the project should you be thinking, how do you know what you don't know? And my answer is, I think you should be thinking about it all the way through. And when you get to the end of your project, Sarah alluded to the repository that the library has set up within the organisation, and we encourage people to donate, if you want, their posters and their outputs from projects to the repository, because that's adding back to the knowledge base. So when I do an evidence search, I look at the existing knowledge base and evidence base to see what's already been done, and we're encouraging people to share that with us so that other people who are coming up behind them in the organisation or even outside the organisation can see what our trust outputs are around improvement, research, evidence, and those sorts of things, to really sort of raise that profile and really sort of make people proud to shout about what the work that they've been doing. Other things that I've got up on the screen here. So as part of my, I have some sort of national work that I do as part of CILIP, which is the Chartered Institute of Library and Information Professionals. So I have professional registration with them. So I'm a chartered knowledge manager with them, and I'm required to keep that professional status and to maintain and revalidate that. I'm also a mentor for them, so I mentor other information professionals to achieve professional registration. I'm also part of an assessment board as well to assess people completing those professional portfolios. I've also had the privilege to represent CILIP and the organisation, our organisation, twice at the CILIP conference, once in 2023 and once this year, just in July, just gone, talking around themes such as imposter syndrome in the profession, and also advocating for the profession, which is a really strong part of what we need to do as professionals to show the impact that we can have on the work that you yourselves do. So what I've hopefully done by showing this slide is showing the impact of looking around, seeing what's done elsewhere. You know, how do you know what you don't know? Ask yourself that question, talk to people. Who do you need in your team? Find out what they know, bring it all together, and, you know, use the evidence and connect with your knowledge and library services to help you with your improvement projects. So that's me and that's us as a team. And I think the next slide is to ask if anybody has any questions. I know we had some questions and chat going on, which I think has been answered as it's been going along, which is excellent. Oh, sorry, I didn't mean to do that. Sorry. But does anybody have anything that they'd like to ask while we're here? Claire.
Oh yeah, thank you for the presentation. That was really interesting, and it's great to hear what you yourselves are doing at Somerset and some of the difference between your team. It's given me a lot to think about as well. I was just curious to know, you were sharing, Jessica, about having those posters of kind of repository of information. I was wondering, do you have a method where you actively record what other improvement projects going on in your organisations, or from the small changes to the big changes? Just something we're kind of trying to do better at our trust.
I'll answer from the repository perspective, and then and maybe hand over to another colleague to answer as well. So for the repository, what we're trying to do, it's very it's a slow process because it's involving a lot of manual upload into the repository. But what we're hoping to use that as is that kind of this is such an overused phrase, one-stop shop for people to look at and see what improvement projects are happening, both sort of ongoing and completed and or maybe reopened, that sort of thing. So we are encouraging people to donate their things to us via sort of promoting it via the training offers that we have. We have like comms that go out about it. We signpost people to the repository. In terms of step-by-step tracking of improvement projects, I don't know if I could maybe hand over to maybe one of the improvement advisors to answer that one.
For me to come in on
Greg,
that one.
Thank you.
Yeah. So it's a massive challenge, isn't it? And we wrestled with it for a long time about how to do it. And you're Sheffield Children's Hospital, are you? Yeah. So
yeah,
no doubt an organisation of some substantial size. We're about 14,000 people in our organisation, and even when we were just a single acute trust, because of the approach that we've got of trying to upskill people and get them to do projects on their own, we don't necessarily know everything that's going on. So we encourage people to record their projects, and at a kind of service group level, they'll be recording them, but we're definitely not capturing everything. The project management team will pick up in a much more formal, structured way the really big things that are going on, the big priority things that are going on. A lot of the rest of it is we encourage them to do it, but we know that we're missing a lot of things.
That's great. Thanks very much. Great. Yeah, similar picture to at the Sheffield Children's. We're a little bit smaller than yourselves as well, so we're not quite as big as our Sheffield Teaching Hospitals partners, but we're still perfectly full.
Thank you. Anybody else? Any questions? The session has been recorded and will be made available after this week, QI week. I did have one more thing that we wanted to share with you. We couldn't sort of let the opportunity go by to do a shameless plug for our quality improvement grand rounds, which are open to everyone. So they're not just for us here at Somerset FT, but anybody can sign up for these. So we run these monthly. And this is a poster for the latest 2 sessions which are coming up. And if you were interested in registering, you can do so by using the QR code on the screen or by contacting our improvement mailbox. And the sessions comprise of 1 or 2 people talking about the improvement project that they've worked through, maybe using the gold training methodology that we have and any outcomes they've had from that, and then are encouraged to, as I say, they're sharing their work. So it's a way of spreading, going back to our 7 steps, spreading the methodology that they've used. So please do come along. You are very welcome to join us.